Good evening, everybody, ladies and gentlemen. Thank you again for joining us tonight. Dr. Fernandes, a special welcome to you. It's always under very difficult circumstances that a doctor has to prepare a talk. And the webinar always has these little jackal and little problems pitching up at the last moment, but so far it seems like everything is going well. Dr. Fernandes has a practice in Behavioural in Northcliffe. He also works with Dr. Kritzinger. Dr. Fernandes, I just want to confirm all your interests. We all know that you are you see a lot of children and strabismus and neuro problems. And I think you've also done quite a bit of glaucoma work with your draining devices and laser. Am I right?
Yes, that's right, Louise.
Anything else that I left out that's like a speciality of yours?
No, I think that's about it. I think all the general stuff, all the stuff that we see quite commonly.
Yes, yeah. But in any case, I hope you have a good talk and we're all looking forward to it. Thank you very much, and over to you.
Okay, everyone. So I'm talking about basically controlling myopia in children. And I've just shared my PowerPoint presentation, so I hope everyone can see it and everything's working nicely. Yeah, so I think this is a very kind of important field, and it's an area that we are really making big strides on, I think, in the last couple of years. And I think it's also very relevant because it's becoming an increasingly increasingly common problem. And I think it's very good news that there's something that we can now do about it. And I think that perspectives in the industry and that are changing quite quickly. And I think our patients will benefit greatly from that. So basically, we are kind of in another pandemic of myopia, particularly in the younger age groups. And just a very scary statistics is that the prevalence of myopia is about 80% in school leavers in areas like China and Singapore. And of those, up to 10 to 20% have got high myopia. So that's an extremely high instance. And these patients are at a lifelong risk of a whole lot of retinal problems and vision problems. Besides needing to wear glasses, contact lenses, or having some sort of corrective surgery, they're at a high risk of irreversible visual loss directly related to their myopia. So there is a lot of kind of geographic variability in this problem. And although the incidence is 80% in kind of Asian countries, it's 30% in Australian school leavers, so much less. However, in Europe, the incidence goes up to about 47%. And what's interesting there is that the highest incidence is in the 25 to 29-year demographic age group. So I'm not sure what the cause of that is, but maybe it's due to a lot of studying, which people are doing in their early 20s. So in fact, myopia is becoming so common that it's projected to become the most common cause of loss of best corrected visual acuity in the future. So that'll be overtaking glaucoma and overtaking macular degeneration, even possibly. So what's very interesting about it is this kind of mixture of environmental, genetic, and racial factors. And we're trying to tease out whether the racial factors are due to different genetics in different regions, or if it's because of different environments that children are exposed to in different regions. And what's interesting is that although people of East Asian ancestry seem to have the highest incidence, when people of East Asian ancestry move to Australia, and you compare the incidence among Asians in Australia and people of European ancestry in Australia, you actually find the incidence of myopia to be around about the same. So perhaps it's not really such a strong racial predilection for myopia, but it's actually an environmental factor in East Asian countries. So there's an institute called the International Myopia Institute, and they basically come up with a whole lot of definitions, which is the definitions that I've been using. So they actually make a definition of pre-myopia, and this they define as people with a refraction between plus 0.75 and minus 0.75 in children where a combination of age, refraction, and other risk factors may merit instituting glaucoma interventions. So they're not myopic yet, but because of their age and risk factors, they're at risk of it later. They define low myopia as between -0.5 and -6, and they define high myopia as being more than -6. And they have a different definition for high myopia versus pathological myopia. Pathological myopia they define as myopia with some sort of retinal complication. And I've just given you a few of the pictures of retinal complications which people can come across. So pathological myopia is a lot of the reason as to why we need to try to limit myopia progression. So besides the optical kind of morbidity from having to wear thick glasses or contact lenses or a very high amount of laser, myopia is an important and increasingly common cause of irreversible visual loss, and that's because of a few of these conditions. So this picture here on the left shows you basically geographic atrophy secondary to myopia, where similar to in macular degeneration, we're getting atrophy of the retina and choroid. You get a similar process in myopia, and that's going to cause irreversible visual loss if the macula and the fovea are involved. This here is a bleed in the fovea. So this person is going to present with sudden loss of vision, very similar to somebody with wet age-related macular degeneration. And the cause of this is a choroidal neovascular membrane, which is formed secondary to the degeneration and thinning and atrophy that goes in myopia. This shows an OCT scan of the retina, and it's showing myopia-associated tractional maculopathy. So the eyeball is so elongated and lengthened that there's traction on the macula, and that is in fact cause this kind of foveal schisis, which in turn is going to decrease vision. These are some of the other complications. So on the left here is a condition called dome-shaped maculopathy. You can see the macula here is basically convex shaped. So normally it's concave shaped, but here it's become convex. We're not completely sure why this happens. Okay, apparently my internet is giving issues. Should I stop sharing?
Gareth, Dr. Hinks said if you could maybe just quickly disconnect your internet and reconnect again. Shall we try that? That means that we might lose you for a second or so.
Okay.
You'll probably have to link on again.
Is that better? Can everyone hear me now? Is the connection better?
It sounds so. Let's see how it goes. Thank you.
Should I just quickly go back? I'm not sure when it started becoming
I think, yeah,
issues.
quietly from the beginning, just after the beginning.
Okay. Yes, so basically the definitions from the International Myopia Institute defining pre-myopia as a refraction between plus 0.75 and minus 0.5 in children where age, refraction, other risk factors merit instituting interventions. We also define low myopia between minus a half diopter and minus 6, and high myopia as being more than minus 6. So these are some of the conditions which result from pathological myopia. So the first one on the left is basically geographic atrophy, which is secondary to a lot of thinning on the retina and the macula, and it looks a lot like dry macular degeneration with geographic atrophy. And yes, you can, yeah, this person's obviously going to have permanent visual loss. Centrally here is a picture of the retina, also a very high myope with a very thin atrophic retina, and it's developed choroidal neovascular membrane. So that's a similar process to what happens in wet macular degeneration, and that's going to cause retinal damage, and there's a bleed in the retina. So we can treat it with anti-VEGF injections, and things should improve. But it's going to have a permanent scar.
Okay. Gareth, can you hear me?
Yeah, I can, yes.
To everybody, very sorry, this is an internet problem. Henk asked whether it's possible that you could link in from a hotspot device. What is it? I don't know if it will help if you somebody suggested that you actually close down your video, so we don't see you, but we only see the lecture. So just let's try that for a minute. So just say what is it? Stop. Yeah, just say stop video.
Wait a minute though. I don't see. Oh, here we go. Okay.
At the bottom on the left.
Dr. Fernandes, I've already switched off your video, so I think let's give it a go and see if it works better without the video. If not, then we can maybe try do a hotspot from your phone with regards to internet.
Okay. Okay, so I was discussing, I'm not sure if you heard that, but anyway, so basically geographic atrophy, choroidal neovascular membrane, and attractional myopic maculopathy. So these are caused of irreversible visual loss among myopes. Other conditions, this is a condition called dome-shaped macula. So as we can see here in this OCT, the macula is convex shaped, normally it's concave shape. And this occurs sometimes in myopia, we don't know why it occurs, but it's associated with various complications. One of them is basically exudative form of retinal detachment. There are some other conditions. So this here is an optic nerve, and it looks just like the optic nerve of somebody with advanced glaucoma. This is a person whose intraocular pressure is in fact normal, and they've got a condition called glaucoma-like myopic optic neuropathy. Also with visual field loss and an optic neuropathy, which looks very similar to glaucoma. And then this picture on the right is a retinal detachment, which, as we know, as you can see here, temporally, we know that myopia is associated with that. So all these conditions are more common the more myopic you are. the cutoff of -6 being high myopia is just kind of arbitrary. So if we can get a patient to be -8 in their adulthood rather than a -9, we'll be decreasing the chances of all these things happening. So I think that's an important thing to keep in mind. Okay, some of the other conditions which are not retina related. Firstly, myopes tend to get cataracts at an earlier age and more severe cataracts than emmetropic and hypertropic people. They're more likely to develop glaucoma, and this is a condition which myopes get called pigment dispersion syndrome, where the peripheral iris is rubbing against the zonules, and that in turn causes glaucoma as well. Okay, so what I really want to discuss is the environmental factors, and because those are what's causing this kind of new myopic pandemic, as I'm kind of calling it. So the intensity of the education system is probably the most important cause. So in cultures kind of before education and where people are living outdoors and that, myopia essentially doesn't exist. And as we start educating our children and putting them indoors and making them do lots of near work, myopia tends to occur in the population. So I'm not saying that we should stop educating our children, but we need to be aware of the kind of complications and the visual side effects of that. So what's most interesting is that time outdoors managed to offset this educational demand. So in other words, if children are spending a lot of time indoors with a lot of near activity, but they still get their 2 hours of outdoor exposure a day, their chances of becoming myopic are far, far less. So time outdoors can offset this problem of very intense UV exposure. Things that also help: bright lighting indoors, so that indoors is a little bit more like outdoors. We think that that helps. We think that it may have something to do with UV light exposure, and that's why they benefit from the outdoor time. So it's important to kind of be aware of our children and how much time they're spending on near work. So it's not good for them to do 45 minutes of near work without a break. The distance to the near work is also important. So children who are working very, very close, so for example, at like 20 or even close to 20 centimeters, are more likely to develop myopia than those working at more reasonable distance. It seems to be worse if they're tilting their head. I'm not sure why that is the case. People with a high level of education are more likely to become myopic. And there's also a thought that it's not just the work, but it's the fact that it's high contrast work that is the stimulus for myopia. And it seems that reading white text on a black background, in other words, sort of first on a normal page or a normal book, it would be cause less myopia than a conventional book. And also screen time. We're not really sure of the influence of that, but screen time is generally near time. Given that the distance of the screen is important, so screen time on a TV is probably less likely to cause myopia than screen time on, say, an iPad or on a cell phone, which is much closer. So in terms of controlling myopia progression, so we need to have a look at behavioral factors, optical factors, and then pharmacological factors. So the behavioral things, I've kind of gone through quite a lot of those in the risk factors, but it's very important. I just want to emphasize the 2 hours of outdoor time a day. So that firstly is, there's evidence that that prevents children who are not myopic from becoming myopic. And there's also evidence to show, it's less strong, but there's evidence to show that if you are a myope already and you spend time outdoors, you're less likely to progress, and you progress slower if you spend more time outdoors. We want people to read with at least 25 centimeters or more from their eyes. We want them to have a break every 45 minutes, and using high illumination indoors seems to be a protective factor. Okay, so behavioral, the pharmacologic intervention. So here the one that I want to talk about is atropine and myopia control. So atropine's actually been used since the 1960s for myopia control. So it's not, there's nothing new about this, but I think what has changed is the concentration. So remember the commercially available concentration, if you buy atropine from a pharmacy, it contains 1% atropine. So that we would call high dose atropine. You can dilute that 1% to 0.5%. We still consider that a high dose atropine. But the big advance of what we've done now is we found that if you dilute that atropine anywhere to 0.01, which is diluting the available atropine 1 to 100, or even 1 to 10, you can by far decrease the side effects of the atropine, but maintain some of the efficacy. So the question is, how does this work? So kind of initially we thought that it had to do with accommodation, that the atropine is paralyzing accommodation. Certainly that's what high dose atropine does.
Dr. Fernandes, sorry to interrupt, Doctor. It sort of feels that if Doctor just pauses for 5 seconds and then start again, that it buffers a bit better, and then the sound's also a bit better. We had probably a good streak of about 8 to 10 minutes now, but it was starting to creep up again. So if we can, if there's maybe also, if Doctor is, I don't know, if Doctor is maybe at some point turning away a bit or something, if Doctor can just try do the same thing until, yeah, sorry, it's a bit difficult.
Okay. Okay, so yeah, atropine's been used since the 1960s, but we found that decreasing the dose decreases the side effects, but we still maintain some of the efficacy. So the question is, how does this work? First, it's got nothing to do with accommodation. So the high dose atropine paralyzes accommodation. However, the low dose atropine has minimal effect on accommodation, depending on what concentration you use and the age of the patient. We don't think that's just a mechanism of action. So we think that somehow it might stimulate collagen synthesis in the sclera, reducing scleral elasticity. Another theory is that it may increase choroidal blood flow. I know that choroidal blood flow is reduced in myopia, and a part of the cause of vascular elongation. And it may also have an effect on retina, something to do with dopamine release in the retina. So the big breakthrough is that you don't have to paralyze with accommodation in order to reduce the myopia progression. Having said that, the higher concentration of atropine, the better the reduction in myopia progression. So high dose atropine has all these side effects, but does result in a 75% decrease in myopia progression. These patients, you would have to obviously put them in bifocal lenses or progressive additional lenses to kind of manage that accommodation. Not generally something we are advocating.
Dr. Fernandes,
so basically,
Dr.
Yes.
Fernandes, I'm sorry to bother you again. I think our reality tonight is that this talk is going to keep on breaking up. And if we make a video, it's also not going to help because the sound is going to be very bad. I want to make a suggestion to all of you. I'm sorry about this. You have all set yourselves for tonight. Let's quit the talk. And then we will find a next opportunity where we can do the talk, just you and the camera. And then I will send the YouTube link through to them. And after they've listened or looked at it, then I can send the certificates. Would that be sufficient to you?
If we have a moment, can I ask the IT person in the family if they would like to see if there's something on our side?
Let's try that, and then I'll just wait to hear from you then.
So okay. Gareth, yeah, I think if you can maybe make a hotspot with your phone and connect to that, we can quickly see if the quality is better. If not, then I think we would have to go maybe with what Louise suggested.
Okay, if you can give me just a minute or two.
And to all of you, I'm going to send the video to you again. Now, I know if the quality of the sound has been bad, we will have to still probably do it over again in any case. But let's just see if the hotspot is working. And then at least you can maybe pick up the second part of the talk, and you can catch up with the first part later.
Hi, Henk. Is the line quite bad on your side?
Henk?
At this moment, it sounds okay. Did you connect to your hotspot now?
No, we've got a 100 meg fiber line, so there should be no need for a hotspot.
I'm not sure for what reason it's breaking up, and the only thing we can conclude is that it's an internet issue.
Is it still breaking up now?
At this moment, it's sounding fine.
We can switch over, Gareth, maybe continue, then just shout if it's poor.
Okay, let's give it a go. It's sounding perfectly now.
Okay, cool. It's weird.
Yes. Okay, so basically this table shows us the side effects as well as the effects of atropine of various concentrations, which I think is good for comparison's sake. So high dose atropine results in pupil
Dr.
dilation.
Fernandes, sorry, doctor's breaking up again. Can doctor, just one more thing, maybe just talk a bit further away from the mic or the computer?
Okay. Okay, is that any better?
Okay, let's give it a go.
So there's a lot of loss of accommodation, 11 diopters with high dose atropine. Near vision is not adequate at about 0.5. Whereas if we make the dose 1/10 of that, pupil dilation is less, 3 millimeters. They still have about a mild optic loss of accommodation, so it's all really not great. Better near vision. It's really not perfect. However, at a very low dose, which is between 0.01% and 0.05%, the side effects become almost nothing. So pupil dilation is half to 1 millimeter, which is really not going to have any symptoms at all. The loss of accommodation is between 0.3 to 4 diopter, which for a child who's really got a lot of accommodation available to them is not really going to affect them. Their near vision is 100%. So really at this low dose, you're having really minimal or any side effects whatsoever. And as you can see, the rate of progression is still maintained despite the lower dose and the less side effects. So at a 0.1% dosage, 11% of patients progressed more than 1 diopter. And at between 0.01 and 0.05%, 18% of patients progressed more than a diopter. So if we consider that the normal progression for this cohort of patients was about 1 diopter, we really have decreased it almost by 80% by means of the low dose atropine. There is one big problem with the atropine, and that is this problem of a rebound effect. So if you stop the atropine suddenly, it seems that then the growth of the eyeball catches up to what it was before. So when you stop it, they get an extremely rapid elongation of the eye. And this effect is called a rebound effect. So it doesn't happen in everyone, but the higher the dose of the atropine, the more this rebound effect is. So with high dose, the rebound occurred in 41% of atropine, with low dose in 27%, and then with a very low dose, 0.01 to 0.05, which is the concentration that I use, the rebound effect was in fact only 8%. You can also really limit this by modifying the age at which you stop the atropine. So if you stop the atropine at about age 12 or later, the rebound is much, much less than if you stop the atropine at the less than 12 age group, which is really the age group where myopia is progressing the most. So the rebound, I think, is a manageable phenomenon, and we just have to be aware of it and manage it accordingly. So I think now, following one of the big studies called the LAMP study, the low-dose atropine for myopia progression study, they've kind of suggested a dose of 0.05% to give you the best balance between efficacy and side effects. I think this is a good dose to start at because it's got great efficacy. And then if the patient does experience side effects on this dosage, you can halve it, or you can even go down to the 0.01%. And then in all likelihood is going to decrease the side effects completely. So besides the atropine, there are optical methods to slow myopia progression. And one of these is with a multifocal contact lens. And I've just given you a little picture of that. This is a lens called a MySight lens, which is shown to be very effective. The optical method, maybe from quite some time ago, is undercorrecting myopes. So this has been shown to really be of no benefit. So undercorrected myopes tend to progress at the same rate as fully corrected myopes, and possibly even faster than the fully corrected myopes. So there really is no place for undercorrection of myopes now. The evidence is really pointing against this and showing that rather than being of some benefit, it is possibly harmful. Never mind, these patients don't actually see properly, so it's going to have an effect on their school performance and everything. So they are working on other lenses, so spectacle lenses, to try to stop myopia progression. So one of them is called a DIMS lens, which is called a Defocus incorporated multiple segment lens. So what this lens consists of is the full correction in the center, and surrounding that full correction in the center is a plus 3.5 ad, which surrounds the entire central zone. And basically with this lens, they showed a 50% reduction in myopia progression. This is a new lens that's not available, but it is promising. I guess it does have the disadvantage of if you turn your eyes and look peripherally through the lens, you're going to have blurred vision. But it has been shown to work. Bifocals, lenses, and progressive additional lenses. So these do slow progression. So there's good evidence to support their use. But just compared with the contact lenses that I'm going to talk about coming on, or the atropine, the effect is relatively small. So they slow the progression, but only by about 1/4 of a diopter a year. Whereas we're talking kind of about half or even more slowing with either atropine or with the contact lenses. So it is certainly an option, but just we must be aware that the effect is basically minimal. So contact lenses. So soft contact lenses and RGP lenses, the progression rates really are the same as for spectacles. So there's no real benefit there. However, there is a big benefit for bifocal or multifocal contact lenses. And there they found that designs with a concentric ring are better than those with a progressive ad design. And an example of this lens is a MySight lens, which is made by Cooper Vision. And they found that after 3 years, you get a 59% reduction in the rate of progression of myopia. So this really is a great lens. Look at those, I suppose, cause a few halos and glare symptoms, but this really is not going to be a big deal for most of these children. And yeah, I think we should really be pushing this, and we should be using it as often as possible to slow down the rate of progression. Just one of the important things regarding these contact lenses and the near and the multifocality is that the stronger the near ad, the greater the effect. So there was a study called the Blink study, and they compared a plus 2.5 ad with a plus 1.5 ad. In the plus 2.5, they managed to slow progression by 0.45 of a diopter, and in the plus 1.5, only by 0.25 of a diopter. So we're talking almost a doubling of the effect with the higher add of plus 2.5. Another one of the things that's known to reduce progression is orthokeratology. So we think that the mechanism of effect is similar to the mechanism of effect of multifocal contact lenses. Basically, this consists of, we use an RGP lens at night, and it causes redistribution of the corneal epithelium, which then corrects the myopia during the day. So on the slide here, you can see the corneal epithelium becomes thicker in the corneal periphery. It becomes thinner in the center of the cornea, and that results in flattening of the cornea centrally, which then decreases the myopia. However, it also causes a change in the shape of the cornea. The peripheral cornea is still going to be relatively myopic, so it almost has this effect of creating a multifocal cornea. And because of this peripheral myopic part of the cornea, we think that that is what slows down the progression. So basically, there's less peripheral retinal hyperopic defocus, which is the same as the mechanism that we think is at work in multifocal contact lenses.
Sorry, I've noticed the audio comes through badly every now and again. I've joined from my phone. Can you unmute here and then the audio can come through on the phone?
Let's give it a go. You must just, then just mute Gareth. Okay. You must just inform me under what name you signed in.
Under David.
Hello. Okay, there we go. I think you should be able to hear Gareth now.
Okay, that sounds good.
Okay, there we go. Continue. Okay, so yes, so basically those are our three kind of armamentarians to decrease myopia: the behavioral, the pharmacologic, and the optical. What about combinations? So there are not too many studies to show this, but they have done a combination of atropine with the orthokeratology, and that has been shown to have an additive and a synergistic effect. In other words, it is worth combining them, and the effect is greater than any of them on their own. And there's also shown to have a beneficial effect of atropine, combining that with bifocals or progression PAL lenses. That study, however, was at the 0.5%, in other words, the high dose atropine. So I'm not a big advocate of this type of treatment because we're basically turning these children into, we're basically making them presbyopic and reducing their accommodation, which is really not great. And then, yes, we can treat them with bifocals, but yeah, I don't think that's really a great treatment. So what's important is for us to, when we're confronted with myopic patients, to identify those who will benefit the most from myopia control. So we really want to look for the risk factors, and in there, the family history is important. So the number of myopic parents is important. Certainly 2 myopic parents is worse than 1, and the degree of their myopia is also important. The environment is important. What kind of schooling are they in? What kind of things do they enjoy doing? Do they enjoy playing sport? I'd put your personality being important, because those children who just love reading and love their near work or on the phone or devices, you know, like the whole day, they are really at higher risk of myopia progression. So we need to consider treating them more aggressively. Also, patients with an esophoria for near, we think it may have something to do with accommodative lag. Patients with an intermittent exotropia. And we kind of think of myopia progression as being something that happens, it is certainly something that happens mainly in children in the primary school age, but also in people of university age, particularly people studying medicine, law, and engineering. They also are at risk of becoming myopic and of progressing kind of into their early 20s. One of the examples is one of the optometrists who worked with Dr. Kritzinger. She started studying optometry. She was kind of plano, and by the time she finished, she was like a -8 or something. So how she managed to progress so rapidly in 4 years of study, I'm not so sure. But this is not something that is isolated just to children growing up. It can also happen in the university years. So this is an example of a child who's really going to benefit. So we need to kind of, when we have a patient with myopia, to get an idea of what we think their refraction is going to be in adulthood. So if we get a patient in the age of 5 to 6 who's only plus 0.75 hyperopic, they already are in fact showing signs of axial elongation. So we could consider them at risk of myopia, particularly if they have a family history. At age 7 to 12 years, patients tend to progress on average by about 1 diopter per year. There's a lot of variation in this. Some progress much, much quicker, but certainly the ages 7 to 12 are kind of the 5 years that we really want to try to use these methods to reduce that axial length elongation. And then older, at about age 13 to 16, the progression tends to decrease to about half a diopter per year. But also there's a lot of variation. So if you're confronted with a child who's 5 and is already, say, a -1 myope, we can say that 5 to 12, that's another 7 years. They're probably going to add another diopter per year. That's going to get them to -8. Between 13 and 15, we're going to have another half a diopter per year. So it's probably get them to somewhere around about -10. So that's definitely a patient we want to treat. However, if you have a patient who say a -1 at age 15 or 16, they are probably only going to progress at about a half a diopter per year, and you may be more likely to kind of let that go, and you're going to be less likely to want to halt that myopia treatment. Having said that, there's a lot of variation. So what's also important is the amount that they progress, say, in the last year. And we get an idea of who's progressing slowly and who's progressing rapidly if we follow the patients up. So the interventions, I think from an environmental point of view, that's kind of almost not something we can be advocating, but it's something that's really in the control of parents and in the control of schools. And we need to encourage children to use a reasonable near distance. We would rather them being on the TV, on a screen that's further away, than say on a desktop computer, and we'd rather than being on a desktop computer than say on an iPad or on a smartphone, because the closer they're working, the more of a stimulus that is for myopia progression. We want them to limit near tasks to 45 minutes, at least have a break every 45 minutes. And we want them to use bright indoor lighting for their near tasks. So in conclusion, myopia is the most common medical condition in school leavers and teenagers. Pathological myopia is an important cause of irreversible visual loss. So environmental factors are important, mainly under the control of parents and schools, and we really need to try to increase awareness among that population. Optical myopia control really is great, particularly the contact lenses. So I would really kind of push people to start using that in their practices. I think it really can make a massive difference. And then pharmacologic myopia control also really has great efficacy with minimal side effects. And I think we should be using it far more often than we are. So thank you, everyone. I hope people heard most of that. I'm sorry for all the technical problems.
Thank you, Dr. Fernandes. I want to make a suggestion. Can I ask you, our delegates, to please send us your questions under the question and answer section. If there are parts in the beginning of the lecture that you might have missed, you only got maybe a few pieces here and there, would you mind just putting it down as a question, and we can see if we can deal with most of that. So we've got a few things in the chat. Let's just go to question and answer. Will you please send us your questions? We'll just wait a minute. Thank you. Let's just give it some time. There are no questions at the moment. All right, there's one question. Please cover the convex macular pathology.
Let me see if I can go back to that slide. I'm not sure if my slides, am I still sharing? Can you see my slides?
I can see it.
Okay, so the normal eye has a concave shape if you're looking at it from the outside through the pupil. And for some reason, in some patients who are myopic, it actually has this convex shape. So you can see the curve is normally, I'm not sure if you can see my mouse. Maybe I should.
We can see your mouse.
Okay. Yeah, I was just wondering if I can make this bigger. No. So normally the curve would be in this direction. It would be concave, looking from the pupil. But in these OCTs, the macula is actually convex. So it's basically got the wrong curve to it. So this is called a dome-shaped macula. It occurs in myopia. We're not sure why. So obviously the peripheral kind of part of the retina has elongated more than where the fovea and the macula are. And for some reason, this shaped macula is then associated with various other macular pathologies. So you can see here, you can develop fluid underneath the retina, which is going to cause a loss of vision. And you can also develop conditions called foveoschisis, where you start getting almost tears between the layers of the retina. And that also causes a reduction in vision. So it's certainly not a common thing, but one of the many ways in which myopia can cause irreversible loss of vision. So something to bear in mind when we're seeing these children is that when they're adults in their 50s, 60s, and 70s, they're still going to be at risk of visual loss. And if we can decrease the myopia progression in childhood, that could protect them in their later years.
Okay, there's another question. Please also repeat the optic nerve pathology associated with myopia.
Okay, so it seems that this is the slide that everyone missed. So the optic neuropathy, it's called glaucoma-like myopic optic neuropathy, and really what it is in the name. So the patients develop visual field loss, so similar to a glaucomatous patient. And they also develop the characteristic cupping that we see in glaucoma. However, the intraocular pressure is normal. So this is not glaucoma. It is, in fact, basically damage to the optic nerve secondary to the myopia itself. So you would it would be a very difficult thing to kind of decide, is it this glaucoma-like myopic optic neuropathy versus normal tension glaucoma in a patient who's myopic. But we need to be aware of this condition. And here, lowering the intraocular pressure presumably is going to have no real effect on the optic neuropathy. So once again, an irreversible cause of visual loss. Basically long after the myopia has progressed and these people are well into adulthood.
Okay, there's another question. Couldn't get if reading white on black background is good or bad.
So a normal book is black writing on a white background. So people have suggested that that is bad and that it's in fact better to reverse things. So if you're reading on your phone, for example, you can make the background black and the writing white. And they think that that is in fact better for myopia progression. It's more of a theory than something that's actually been proven. But we've been kind of blaming myopia progression on a lot of the near work. And what these authors suggested is that maybe it's not so much the near work, but the fact that it's the high contrast that's driving the myopia. And that by reversing things to white writing on a black background, as you can do on a Kindle or a smartphone, in fact, the myopia progression may be less.
Okay, when to do this atropine therapy?
So I think you need to look at, firstly, we need to, I think for all myopes, they must be made aware of the behavioral interventions. So all myopes or pre-myopes or people who are at risk of myopia due to their family history, I think need to be aware of the behavioral interventions. And that certainly is a starting place for everyone. And I think it's a starting place almost from a public health point of view. Failing that, the optical devices, especially the contact lenses or the orthokeratology, really are a great addition. And then the atropine, certainly, I think, look, unfortunately, there's a huge barrier to the atropine in terms of getting somebody to prescribe it. And it's not really easily available because it has to be diluted by someone. Pharmacists don't really dilute eye drops anymore. So there's in fact there's a chemist called Fagron, and they are compounding chemists, and they make a lot of basically mix a lot of eye drops for themselves. And one of the things that they mix is the atropine. So people can get hold of this chemist. It does mean it's more expensive because somebody is physically mixing it at this pharmacy, and they deliver it to you. Yeah, and then people can use that form of the low dose atropine. So yeah, I think it's a problem that there's such a big barrier to it. In the East countries, so in China and in East Asia, this low dose atropine is available at a normal chemist. So hopefully one day the same thing will happen in South Africa, and then we could simply prescribe it, and patients could get it. I mean, the other problem is that it has to be prescribed like by a doctor, and that just creates a whole lot of barriers because there's no way that I can prescribe atropine drops for all the myopes in the country. So yeah, that's another barrier. So kind of a regulatory barrier that kind of I think we really need to kind of get over, so that we can have as many myopes as possible on this treatment, because really the side effects are minimal, and I think the benefits really are great in the long term.
Willem Petersen said we would like to include atropine 0.03 to 0.05% with our Orthokeratology, I suppose, patients who can help with atropine compounding.
Yes, so there is a pharmacy, they're called Fagron. They mix a whole lot of ophthalmic drops, and they do dilute it for you. And you basically just ask them for whatever concentration of atropine you would like, and they will make it for you, and they deliver to the patient's house. So yeah, definitely an option. It's just obviously more expensive than a drop that you can buy over the counter. Sorry, can I just go back? I think I kind of got distracted and didn't answer that other question as to how do you decide who you should give this to and who you shouldn't. So I think for that, I think the best is to go into the what you expect this patient to be when they are an adult. So if you go through the formula of in primary school, they are likely to progress by 1 diopter per year. In high school, they're likely to progress by half a diopter per year. And you've got their age and their current prescription, you can kind of make a guess as to what you think they're going to be in adulthood. And certainly the higher they are going to be in adulthood, the more likely you're going to want to put more of these interventions in place. So yeah, I think that's how to kind of decide who to treat and who not to treat. And it's quite easy to remember the 1 diopter per year in primary school, half a diopter in high school.
There's another one. Would there be a greater reduction in myopia if you combine atropine with multifocal contact lenses?
So no one's actually specifically done a study on that, comparing it to one by themselves versus nothing at all. There have been studies comparing orthokeratology with so combination orthokeratology plus atropine, and they suggest that the effect is additive. So it is worth adding 2 of the control mechanisms on the same patient. So yes, I would say the most likely, for example, a MySight lens combined with atropine will be better than either atropine alone or the MySight contact lens alone. That's probably the case, but is yet to be proven. So we're kind of awaiting that. And I'm sure people are working on this, because this is kind of our knowledge, now that the MySight is available and is registered for use in children, the number of studies in this area is really going to explode. So we're going to have a good answer for that in a couple of years' time, I think.
Okay, what is the usual dosage for 0.05% atropine? 1 drop a day or more?
Yes, so all these concentrations are 1 drop per day. Yes.
For how long? Sorry?
Usually at night. Well, the how long really is the problem. So ideally, we want to use it during the ages where myopia progression is the most, which is generally between the ages of 7 and 12. However, this you really need to individualize. So if a patient at 12 has not progressed over the last 3 years, you may want to consider stopping the atropine. And rather than stopping quickly, we rather go from the concentration that we're on and we decrease it to the 0.01. And then once they've been on the 0.01 for a year, we stop it completely because of this problem of rebound. And we know that the problem of rebound is less if they're on a very low dose of atropine, and the lowest is the 0.01. So that is the problem. The problem is that if you're going to do this, it's only really going to make a difference if you do it for a long time. So the patients need to be committed to basically 5 years of treatment, and perhaps even longer.
I think you've answered half of this. My niece and nephew, aged 10 and 8, both have plus 0.2.5. 1.5 left eye only. I don't understand this optometric lingo. It's Muaka Zamchia. We'll go back to you now. Can one apply myopia control in adults showing a rapid increase in myopia?
So once again, no studies, because adults who progress that rapidly are quite difficult to come by. However, we would imagine that the factors are similar as the factors that cause progression in childhood. So certainly one could try these things. The atropine, you see, children have a very large accommodative reserve. So if you reduce that a little bit with atropine, they're not going to have any symptoms. However, someone in their 20s, the atropine may in fact have side effects, so presbyopic side effects. So I'm not sure about the atropine, that they would be more likely to have side effects than the children. However, there's only one way to know, and that's to try. But I would say these multifocal contact lenses, that would really be a great thing to try for these young adults who are progressing.
Okay, I just want to check. Kutlu said, can we go over slides 5 to 8? That's when the sound was bad. I think let's just skip that for a minute and do that last, because it might be a bit long. So those that really would like to have a look at it can stay on for that. I'm just checking all the other questions. I have heard about scleral cross-linking. What are your thoughts on this?
I couldn't find any. So, well, basically, there are lots of techniques to say, well, why can't we directly stop the eyeball from elongating? So various things have been tried. One of them is scleral cross-linking. So if we decrease, or if we strengthen or make the sclera more rigid, it will be less likely to continue to stretch, and there'll be less elongation and therefore less myopia. As far as I know, the cross-linking caused damage to the underlying choroid and retina. So it really was a kind of complete failure. I don't know, that was just one of the studies. Maybe people are trying other techniques. There are other kind of things looking directly at preventing the globe from stretching, kind of slings that they're putting around the eye to physically prevent the eyeball from growing. So there are also people suggesting injecting things behind the globe. to kind of increase the strength or put pressure on the back of the eye to prevent the elongation. But this is all really experimental. So yeah, maybe one day we'll kind of hit the jackpot and one of them will work. But for now, nothing's kind of, you know, commercially available.
Okay, there's somebody that said Fragron is a compounding pharmacy based in 14th Avenue in Fairland, for those who are interested to know that. Any comment on potential long-term damage to cornea health with orthokeratology?
I think the main fear is risk of microbial keratitis. However, that's really been shown to be low. So I think if I remember correctly, if you look at the incidence per 10,000 kind of contact lens years, for orthokeratology, the risk of microbial keratitis, I think for 10,000 years was, I don't know, something about 2 or 3 cases, whereas the risk for soft contact lens was about 20 cases. So in fact, soft contact lenses are more likely to have a microbial keratitis than orthokeratology. And as far as I know, I mean, I suppose you can get corneal neovascularization, but these are all things that kind of can be monitored and the things that can happen with ordinary soft contact lenses as well. So I think the fear from orthokeratology is kind of becoming less and less, and we're finding it as a really useful way of decreasing myopia progression. So I think it's a good thing to add to your armamentarium if you can do it.
Is there any evidence to suggest refractive surgery may slow myopia progression?
Well, no one's done it. I mean, we just can't laser children. It's as simple as that. We won't get ethical approval. Yeah, so I don't know. And we can't do it anyway. I mean, potentially you could laser it like old-fashioned lasering, where you only treat at the center of the cornea, and you kind of almost creating a multifocal cornea. So it would almost be like wearing a multifocal contact lens. But then, of course, they have all the side effects of the halos and the glare, which they're going to have lifelong. So we really don't want to do something like that. So no, I don't think anyone's tried it, and I don't think anyone's going to try it.
What are the intervention for 5-year-old who is plus 0.5, for example, not just environmental?
So I think the first thing is to make sure that they are really plus 0.5. So you really have to do a cycloplegic refraction to confirm that that is in fact what their refraction is. So I don't really trust children at all. So I do a cycloplegic refraction almost routinely on most of them. Yeah, so, but somebody who is, I mean, now they really are just at that cusp of normal. So if that was my kind of relative or my child even, I would really push the behavioral things more than the medical things. So I wouldn't put that child on atropine. I would get them to spend time outdoors, and I would do that by getting them into all sorts of sports, no matter what you can do. You know, making sure they have breaks. I would limit their screen time. I'd move their screen time from their phone to the TV, for example. You know, children who've all been working via Zoom for the last year or two, rather do their kind of Zoom things on the TV, which is at a reasonable distance, than our smartphone, which is very close. Yeah, so for patients like that, definitely the behavioral modifications, I would say, would be the most important. And then, of course, to watch them. And if they do start progressing, then contact lenses are not really a great option for them. So then I would really start thinking of the atropine, particularly if they have other risk factors. So particularly if their parents are myopic, their parents are highly myopic. Yeah, I think the atropine would be the ideal treatment for them.
Mwaka, if you're still on, I would like to ask you to send me your question to my email address. I will forward it to Doctor. Do you think we can quickly go through slides 5 to 8? Just maybe do an overall there, if there's anything that somebody might have missed.
Okay. Am I still sharing? Are you getting my talk?
You're still sharing? I can get it, yes.
So this is where, okay, so this is where the problem came in. Okay, so I mean, these, I think, this is kind of not that important, because this is something that you're going to get in myopes who are older, and okay, that causes loss of vision. But I think most of you would recognize these things and would send the, you would refer the patients on to us, you know, very rapidly. But let's go through it. So basically, this person has got myopic maculopathy, and they've got these big atrophic patches. So what's happened here is essentially the RPE and the retina and the choroid have atrophied, they've degenerated, they've disappeared on these portions. So you're looking straight on sclera. That's why everything looks white on these patches. So these areas of the eye are completely blind. So they're going to have absolute scotomas for this part of the retina. They may have reasonable visual acuity. I mean, it's difficult to say where their fovea is. But as this atrophy continues and when the fovea gets involved, their visual acuity will go down dramatically. Just like a patient with advanced macular degeneration, they're probably going to end up with something like counting fingers or even hand movements vision if this progresses. So here's another, this picture also shows the atrophy. So this person is going to have a blind spot in their superior field corresponding to this area of atrophy. But what I really wanted to show you on this is a choroidal neovascular membrane. So myopes, just like patients with macular degeneration, can get sudden onset of blurred vision, metamorphopsia, things that are supposed to be straight appear to be bent, things can appear smaller than normal or larger than normal, and that can be because of a choroidal neovascular membrane, just as you get in wet macular degeneration. And the treatment's actually quite similar. We give them anti-VEGF injections, and that causes the neovascular membrane to regress, and the vision usually improves. But depending on where the neovascular membrane is, their vision may not come back down to baseline. So this is also called a Fuchs spot. It can, after the membrane has been there, it can result in a macular scar. Yeah, and that's also long-term loss of vision. This picture here on the right is basically what happens is, because the eyeball is so elongated, there's traction on the retina. So that traction is pulling the retina forward, and the retina is trying to stay stuck down to the RPE. And that traction can actually cause cavities to develop in the retina, and that's called a foveoschisis. So this is not fluid like we get in diabetic macular edema. It's not because of leakage. It's actually because the retina is being stretched and pulled apart, and that damages the photoreceptors and also causes irreversible visual loss. The next slide is this one called dome-shaped macula, where you can see the shape of the macula here is convex rather than concave. So for some reason, the elongation of the eye is more in the peripheral of the retina than at the fovea itself. And patients with this dome-shaped macula can get problems of serous retinal detachments and macular holes and all sorts of other maculopathies. So that's called dome-shaped macula. It's really something that you can see by OCT. This one is a picture of the glaucoma-like myopia-associated optic neuropathy, which is basically where there is visual field loss and optic nerve damage in a pattern that looks very similar to what we commonly see in glaucoma. However, the cause of it is not high pressure. The pressure in these patients is normal. The cause of it is, in fact, the high myopia. So once again, optic nerve damage is an irreversible cause of visual loss. And then the one that I think we're all quite familiar with is a retinal detachment. So myopes are more likely to get a retinal detachment than the rest of the population. If you want to kind of calculate the risk, basically every diopter of myopia causes a 10% increase in your risk of getting a retinal detachment. So if you're even just a -3, you're about 3 times more likely to get retinal detachment than a non-myope. If you're a -10 myopic, you're about 10 times more likely to get a retinal detachment than a non-myope. So every kind of diopter of a myopia increases your risk of getting a retinal detachment further. And retinal detachments, okay, if we find them early, we can treat them and there can be minimal morbidity. Often, however, patients don't know what's going on. We get it late, and they can also have irreversible visual loss. So these are some of the other things that are associated. So myopia doesn't only affect the retina, but also affects the anterior segment of the eye. So myopes tend to get cataracts at an earlier age than emmetropic people. So they then have to have cataract surgery at an earlier age than emmetropic people. They're more likely to get real glaucoma, in other words, to have an elevated intraocular pressure. And their nerves are more sensitive to lower levels of elevation of the intraocular pressure. So myopes are more likely to get glaucoma and are more likely to progress if they get glaucoma, and are more likely to get glaucoma at a younger age. So we really need to be more aware of that for glaucoma patients. And then this is a syndrome called pigment dispersion syndrome. So in this patient, basically, because the anterior chamber is so deep, because the globe is elongated to such an extent, the iris actually starts to rub on the zonules. So whenever the pupil size changes, the iris rubs on the zonules and you get loss of pigment of the iris where the zonules are. So if you shine your slit lamp straight at the pupil, you get a red reflex shining back, and you can see the red reflex shining back through the peripheral iris here where that pigment has been lost. So that pigment floats around the anterior chamber and causes the pressure in the eye to increase. So that in turn can cause headaches and blurred vision if the pressure spikes. So the pressure can spike to 30 or 40 or 50, and they suddenly get these headaches. If it goes on for a long time, the pigment can in fact block the trabecular meshwork, and they can end up with a pigment dispersion glaucoma, which then needs to be treated with glaucoma medication. So this is something that's not that uncommon. So we see it, and often it's just an incidental finding. Most of these patients with the pigment dispersion syndrome are asymptomatic. Pressure may be a little bit high, and in fact, usually it burns out as they get older. But yeah, still a kind of something to look out for. And I think this test of shining the slit lamp directly through the pupil and looking for those retroillumination defects is quite a good thing. You'll often see defects in patients who've had cataract surgery or any kind of iris damage or iris atrophy. Yeah, so that's pigment dispersion syndrome. So then the environmental factors, so these are mainly the risk factors, and so these kind of tie in with our treatment of myopia. So most of the things that I mentioned here, I also mentioned again in treatment, but the patients that we want to treat are the ones with a lot of risk factors. So the intensity of the education system is important. So we think that the education system, especially in the Far East, they're doing so much near work, and that's why they have so much myopia in the Far East. A time outdoors is a protector from myopia. So children should be encouraged to spend at least 2 hours a day outdoors. Yeah, basically, I think 1 hour a day decreased your chance of becoming myopic by about 25%, and 2 hours a day decreases your chances by about 50%. So
We've lost you. Are you there? If any of you are still there, I think we'll just conclude this talk. It really seems like we're having problems with our technology. I am going to ask you to send any questions to my email address, louise@visiomed.co.za, and I will send you the video link afterwards, and then you can just scroll to wherever you want to catch up on the talk. I will send you certificates also as soon as possible. Thank you very much. Have a lovely evening. Bye-bye.